Welcome back for the third session of the VSPNT. We are in the midst of the nose discussion, so we can resume back for the session. First disease that we are going to see is atrophic rhinitis. So, what is the name implies? Atrophy rhinitis. If some structure over the nose goes for atrophy, it is atrophic rhinitis. So, what is the firm or hard structure seen in nasal cavity? It is obviously turbinate. So, it's nothing but the turbinates getting for atrophy. It is atrophic rhinitis. How many turbinates are there? Superior, middle, and inferior turbinate. So, what is the cause? It is nothing but a bacterial colonization. So, bacterial colonization by Klebsiella ozone. So, as the bacteria name is Klebsiella ozone, the other name for the atrophic rhinitis is also called as ozone. Now, what is the pathogenesis? The bacteria is coming and colonizing the nasal cavity like this. What is the reason for colonization? The nasal cavity is having deficiency of vitamin D and then estrogen. So this theory is called mechanical theory of Zoffel. So unhygienic bacteria due to deficiency of vitamin D and estrogen getting colonized by a bacteria is called as mechanical theory of Zoffel. Okay, if there is too much of atrophy, it will lead to a roomy nasal cavity. So it is also associated with a greenish crusting, which is creating some epistaxis. It is also destroying the olfactory nerve, which is causing anosmia for this person. So we smelling discharge, which is not felt by the person himself. It is merciful anosmia. It's a very important one liner. So roomy nasal cavity, merciful anosmia, greenish crusting, triad of atrophy rhinitis. Okay, if it is an initial condition, you just have to remove the crusting and you do nasal saline washing. So any material you could use it for it just to cleanse the bacteria, mostly saline based. There are many proven entities are there, but all of them are almost saline based, so you don't have to go that in detail. Surgical management. So you just think like this: how a bacteria will thrive? It is thriving on oxygen from the air. If we close the nostrils, but the bacteria will have oxygen for breathing. Yes. So if we close the nostril, that will cut the air supply for the bacteria. That results in deterioration or improvement of the atrophic rhinitis. It is called as Young's procedure. So you have to close one nostril at one time. After 6 months, we have to go close the next nostril. It is called as Young's procedure. So I have to do it for both the nose at the same time. You have to leave at least 1 mm gap between the nostrils, and you close both the nostril at the same time. It is called as modified Young's procedure. Fine. So moving on to the next VSP, foreign body nose. Can you see in this picture? You could see a greenish bead like foreign body over the nose of the child. So what is the peculiar symptom? Unilateral foul smell and discharge, occasional epistaxis. Always think of foreign body in a pediatric age group. So you should remove immediately. If it is not able to remove immediately now, it can enter into the airway. Okay, a child of 12 years has a stone inside the nose. He is not aware of it. It has lodged into a perfect position, but over a long period of time, it could cause chronic granulomatous reaction. Chronic granulomatous reaction due to a foreign body inside a nasal cavity, forgotten foreign body, it is called as rhinolith. What is the treatment for this rhinolith? Excision. Could do an endoscopic excision. Moving on to the next VSP, we are having three R's. Okay, you have seen a movie called RRR. Similarly, we are having three R's in rhinology. One is rhinosporidiosis. The next one is rhinoscleoma. The third one is rhinophyma. What are the differences between three R's? The first R, rhinosporidiosis. It is caused by a protozoa. That is the main difference. So, what is the name of the protozoa? Rhinosporidium seabury. Now, this spores will be seen over the cow dung. Very important, seen over the cow dung. Now, we are bathing in a two different water supply. One is river, the next one is pond. The river will be having free flowing water, no problem. But this pond will be having stagnant water. When a boy is swimming inside the stagnant water, the cow dung material can enter into the nose. The cow dung material, which is containing spore of rhinosporidium, can enter into the nose, that can eventually lead to a disease called as rhinosporidiosis. When we see like this, you could see a polypodal spore filled reddish mass seen over the nose. This is a reddish mass causing nasal obstruction and epistaxis, a pathognomonic feature of rhinosporidiosis. How can you halt the growth of this mass? You could use a dapsone. If you give dapsone for this nasal mass, that can lead to shrinkage of the tumor. The second one is surgical management. The problem with this rhinosporidiosis is very, very, very vascular. So if you remove it, it could cause a lot of bleeding, and also it could cause a recurrence. So you should excise the tumor and you should cauterize the base. So if this is the tumor, this is the base. The tumor should be excised and the base should be completely cauterized like this. So this cauterization will affirm the bleeding arrestage, and also the recurrence can be prevented with this. Okay, the next are rhinoscleroma. The first one caused by protozoa, the second one is caused by a bacteria. So what is the name of the bacteria? It is Klebsiella rhinoscleromatis. Klebsiella rhinoscleromatis. So this is colonization of the bacteria over the nasal cavity. What it will cause? First, it will atrophy the turbinates. The first stage is atrophic. It is similar to atrophic rhinitis. Now, the second stage, the nose will appear a boggy, woody appearance called as granulomatous stage. This is called as Hebra nose deformity. Hebra nose deformity. Can you see this is the Hebra nose? The person is having a granulomatous nodules and woody feel over the nose. The third one, a chronic granulation happening over the nose can shrink the size of the nasal cavity, causing cicatricial stenosis of the nasal cavity. So atrophic, granulomatous, cicatricial. I am going to take a sample from this. I am going to do a histopathological examination. I could see a Mikulicz cell and then Russell bodies. Mikulicz cell is a histiocyte having the bacilli. Histiocyte with bacilli, which is the causative bacilli. Russell body is an inclusion body. It is an inclusion body. Now, the third R is rhinophyma. If the person is having hypertrophy of sebaceous gland, it is called rhinophyma. The other name is potato tumor. Now, you should do a CO2 laser excision. CO2 laser excision for this patient. So 3R. One is a bacterial disease, one is a protozoal disease, one is a benign tumor. So you should never forget the 3Rs. The next one is septal diseases. See here, the septum is the midpoint which is divided into two nasal cavities. If this one part of the septum is having a pathology, the other part can also have the same pathology. Example is involvement of one septum getting infection can affect the other side also. See here, this is a septal abscess. This is a septal abscess. So the both sides are getting affected. If there is delayed incision and drainage, that could lead to erosion of the septal cartilage. So what you have to do, you should do incision and drainage as early as possible. Fine, sir. Infection affecting the septum causing septal abscess. Okay. What about a trauma over the nasal cavity? A trauma over the nasal cavity can cause hematoma over the nasal septum. See here, a trauma over the nasal cavity can cause, so it is a reddish swelling over both sides, it is septal hematoma, or a foul smelling swelling over the both sides is called septal abscess. Okay, that is the difference between a septal abscess and septal hematoma. Both has incision and drainage as the treatment for it. Fine. Now I'm having a disease called septal perforation. See here, can you see the perforation? Either it can happen following a surgery, can happen following a trauma, can happen following a systemic disease. Fine. What other systemic diseases can cause nasal septal perforation? If it perforates only the cartilage, it is leprosy, TB, or sarcoidosis. If it affects bone alone, it is tertiary syphilis. Very, very, very important. If it affects both the cartilage and bone, it could be vaginous granulomatosis. Both cartilage and bone going for a perforation, it is vaginous granulomatosis or granulomatosis polyangiitis, septal perforation. Treatment, you could use a septal button to close the defect or flap cover. Or you could use a flap cover. Fine. So now I'm having a fracture nasal bone. You just look into this skull bone. Among the bones of the face, which is more prominent? Nasal bone. So among the facial bones, the most common bone getting fracture is nasal bone. So this nasal bone, right side, left side, both are united at the midpoint. If this nasal bone getting fractured, it is displaced from its anatomical position, can lead to nasal deformity. So if the nasal deformity. So you have to do surgery only if you have a nasal deformity. Okay. Sometimes a fracture nasal bone can associated with septal fracture. So see here, if this is the nasal septum. Now if the blow is from below like this, there will be vertical fracture line. If the blow is from the front like this, there will be horizontal fracture line. Okay, these are the two difference between the septal fractures. One is a Chevrolet fracture, vertical fracture line, Jarjeway fracture, horizontal fracture line. Now if the person feels that I'm having a nose deformity, I want to get corrected, you should do surgical correction. So the surgical correction is usually closed reduction. Now undisplaced fracture without nasal deformity, you don't have to correct it. Displaced fracture with nasal deformity, immediate reduction can be tried before edema formation. In the question, if you see the word edema, you should never do a close reduction. Otherwise, what you should do? Till 5 days, you should wait for the edema to settle down. So 7 to 21 days, you should do the close reduction by local anesthesia or general anesthesia. And also, you should never attempt a reduction after 21 days because at that particular position, fibrosis would have settled in. So now, if you remove the bone, the fibrosis may be disturbed and it may result in permanent deformity. So if you want to do 7 to 21 days, you should do. Ideal is 5 to 8 days is the best time period. So no edema, you could try immediate reduction within 2 hours or 3 hours. But edema is there now, you wait till the 5th day time period. 7 to 21 days you could do anywhere around, but you don't do after 21 days. So what are the instruments used for close reduction? Ash forceps used for nasal septum, Walsham's forceps used for nasal bone. Fine. What are the other facial bone fracture? Fracture zygoma, it is results in tripod fracture. Fracture flow of the orbit results in blowout fracture causing teardrop sign. Teardrop sign. The two important named sign in facial fractures. So zygoma fracture, tripod sign. Floor of orbit fracture, teardrop sign. Now getting into CSF rhinorrhea. Just look into this picture. What is CSF rhinorrhea? If the roof of the nasal cavity getting damaged to any of the causes like road traffic accident or a spontaneous leak in an obese individual, or following fist surgery, or if there is some infection passing between the cranial cavity and nasal cavity. So this can be the reason for that. Now, there are two sites described. If it is following a road traffic accident, it is at a site called fovea. It's very, very, very important. This you may not see in many of the books. The most common site for road traffic accident causing CSF anorrhea, it is fovea ethmoidalis. Whereas in case of a cribriform plate of ethmoid to be the most common site, what are the underlying cause? One is spontaneous leak in an obese individual or doing surgery in a fist. Then spread of infection between the cranial cavity and nasal cavity. All these conditions can happen in a cribriform plate of ethmoid, whereas in trauma, fovea ethmoidalis can be the reason. Now, how can you diagnose a CSF rhinorrhea? First, non-sticky CSF fluid. It is confirmed by reservoir sign. What is reservoir sign? See, on lying down, the patient may not get the symptom. On bending forward, there will be gush of fluid coming out of the nose of the person. See here, this is reservoir sign. Can you see? On bending down, can you see the gush of fluid coming out? So on lying down, all the fluid would have got collected over the nasal cavity. On bending forward, the person will have the reservoir sign positive. This is very important. The second one, you wipe out the secretion with a handkerchief. If the handkerchief become stiff, it is URI. If the handkerchief doesn't become stiff, it is CSF rhinorrhea. So non-sticky, it is handkerchief test positive. Then if you place the CSF fluid from a trauma, okay, the trauma will have CSF fluid as well as a blood collection. So a collection which is filled with CSF as well as blood, you are going to place it over the white cloth like this. So having high specific gravity, blood will settle down at the center. The CSF fluid will form a halo around the center. This is called double density sign or halo sign. Halo or double density sign. All right. So this is important clinical signs for diagnosing CSF anorrhea. Investigation. So you collect the fluid, you send for CSF analysis, you get a beta 2 transferrin higher levels. Now it is best to test for confirmation. Beta tris protein can also be tried. The gold standard test for doing this is CT cystanogram. Okay, sir, the defect is only 2 mm size. Still, I want to do a surgery. What shall I do? You do a lumbar puncture, inject a intrathecal fluorescent dye. On the table, you may get the colored fluid, colored CSF fluid that can be done before doing a surgery. Okay, so CT scintigraph for diagnosing. Intrathecal fluorescent dye before doing a surgery if you are unaware or if you are not sure where the leak site is there. Okay, so you could do a treatment of endoscopic CSF leak repair. Got it? Yes. Next is anatomy of nasopharynx. Just look over here. This is the skull bone. So this is the nasal cavity which I'm talking about. I'm going to go from behind posteriorly. Okay. On posteriorly, if you see over here, so this is the nose which I'm going posteriorly now. So posteriorly, if you see now, so this particular area which I'm talking about is the nasopharynx. So this is the nasopharynx. What are the boundaries of the nasopharynx? Very, very important. They have asked this question twice. So what are the boundaries of the nasopharynx? See here, in the roof, I'll be having the skull base. Posterior wall, I'm having the vertebra. Lateral, very, 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 very important. I can lead it to a fossa of Rosenmuller first. Then torus tuberis second. Eustachian tube opening third. So both the structures of fossa of Rosenmuller and eustachian tube opening very, very important. Fossa of Rosenmuller, they asked twice in the exams. So the side behind the ridge is called as fossa of Rosenmuller. Anteriorly EC nasal cavity, inferiorly oropharynx. Okay. So as it is leading to lateral wall eustachian tube opening, it can cause pressure difference over the eustachian tube opening in diseases such as carcinoma nasopharynx as well as adenoid hypertrophy, which are predominantly nasopharyngeal diseases, but it can cause problem over the middle ear due to blockage of the eustachian tube. Okay, getting into the proper diseases of the nasopharynx, the first disease that we can come across is juvenile nasopharyngeal angiofibroma. As the name goes, juvenile means it is juvenile age group, adolescent males. Why only males are getting affected? Because it is a testosterone predominant tumor. Okay, sir. Which is the most common site? See, this is a site called sphenopalatine foramen. The most common site is sphenopalatine foramen. So what it will cause? See, it is arising from the sphenopalatine foramen, causing a nasal obstruction, and also the child will look like a frog face deformity. Very, very important one liners in the question. If you come across the word nasal obstruction, hyponasal voice, frog face deformity, you think of JNA. Okay, what is the important thing? You should never take biopsy from this. You do a axial section of CT facial bone, it will show pushing the posterior wall of the maxilla. This is the posterior of maxilla normal side. Abnormally, it is pushing the posterior of maxilla anteriorly. That is called Holman-Miller sign. Very, very, very important MCQ. Okay, sir. I've diagnosed this. What can I do? The best treatment is endoscopic excision. You should do a endoscopic excision for this child. Understood? Now, we're having carcinoma nasopharynx as the next entity. So, if there is tumor over the nasopharynx like this, this is carcinoma nasopharynx. What is so important in this? See here, it is a Chinese tumor. So, Chinese use smoked fish. That is the reason for Chinese getting more of this tumor. What is the organism associated with this? It is Epstein-Barr virus. Okay. What is the HLA associated with this? HLA-B7. What is the commonest site? It is fossa of Rosenmuller. Now, another important one-liner concerning the CN nasopharynx, it is Trotter's triad. In Trotter's triad, you will see temporoparatal neuralgia, palatal palsy, and conductive hearing loss due to blockage of the eustachian tube. Okay, sir. Where can I see the tumor further spreading? So I have told you already, if it goes above, it will cause brain metastasis. If it goes behind, it will cause spine metastasis. If it goes anteriorly, it will cause nasal obstruction and epistaxis. Inferiorly, very, 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 very important. Inferior spread of the tumor into the oral cavity, oropharynx, can cause painless cervical lymphadenopathy. Painless cervical lymphadenopathy. All right. So lateral, it can cause eustachian tube involvement causing serous otitis media. Okay, very, very important. So a person 60 years coming with eustachian tube blockage showing serous otitis media, you do endoscopy, you find out that it is a CN nasopharynx, you should take biopsy and should treat the condition. So type of impedance audiometry graphs seen in CN nasopharynx is type B curve. So what is the best treatment? As the structure is critically located, you can't just do excision. So best initial treatment is radiotherapy. Okay. So if it is not able to control the tumor, you may do surgery, but initial treatment is radiotherapy. So that's all about the carcinoma nasopharynx. So getting into the next disease of the nasopharynx, adenoid hypertrophy. So if the adenoid gland goes for hypertrophy, it results in adenoid hypertrophy. So see here, there is no scope for nose breathing. Instead, the child will open the mouth and do mouth breathing. So usually the mouth is not a candidate for doing continuous breathing. So for that reason, The mouth become anatomically modified for doing mouth breathing. A chronic adenoid hypertrophy, untreated, not doing any surgery, it can lead to a phasis called adenoid phasis. What that adenoid phasis indicate? High arched bladder, crowded maxillary row of teeth, loss of nasolabial fold, pinched up nostril, sunken eyes, pursed lips, elongated, expressionless face, short upper lips, hypoplastic maxilla. These are all the features of adenoid phases. Why it is happening? Chronic nasal obstruction and mouth breathing leading to adenoid phases. The treatment, adenoidectomy in rose position. Adenoidectomy can be done with cold steel and also coblation. So coblation is the best method for doing adenoidectomy in a rose position. Understood? Yes. So acute infections of the larynx. So see here in this X-ray image, you could see a steeple sign. So the steeple sign is seen in an infection called laryngotracheobronchitis. So laryngotracheobronchitis is a subacute infection. The causative organism is parainfluenza virus A and parainfluenza virus B. The radiological sign is steeple sign. So there is subglottic accumulation of mucus. So croup, otherwise called acute laryngotracheobronchitis. Now, on comparing this steeple sign with another distinctive entity called epiglottitis, this is an acute infection. This is an acute infection. So this will have important sign called thumbprint sign, which is a radiological sign. Now, the epiglottis is closing the laryngeal opening that will cause stridor for the person. So the child will acquire position called bending forward, keeping the hands like this. This is called tripod sign. So hands are put forward, then two legs. So this is called tripod sign for the child. This is a clinical sign. This is a clinical sign. This is a causative organism. Previously, in unimmunized era, Haemophilus influenza is the most common causative organism for acute epiglottitis. But slowly, it is becoming pneumococcus, which is having an upper hand. So, in the option, if you see Haemophilus influenza, you still choose Haemophilus influenza. Latest Card Brown tells that only. But in the option, if you see pneumococcus, you can choose pneumococcus. Okay. So, as Card Brown is the gold standard textbook, latest Card Brown tells that still Haemophilus influenza has more incidence than pneumococcus. You can still choose Haemophilus influenza as the answer. Next question, Zenker's diverticulum. So at the posterior pharyngeal wall, see over here, the posterior pharyngeal wall will be having superior constrictor, middle constrictor, inferior constrictor. The inferior constrictor is divided into two distinctive muscles called as cricopharyngeus and then thyropharyngeus. So between the cricopharyngeus and the thyropharyngeus, there is an area called Killian's dehiscence or Killian's triangle. So this is a weak area over the inferior constrictor muscle. This weak area is prone for herniation of the pharyngeal mucosa. The herniation of the pharyngeal mucosa through the Killian's dehiscence is called as pharyngeal pouch or Zenker's diverticulum. Pharyngeal pouch or Zenker's diverticulum. What will happen? So on eating, a little bit of food particle will enter into the pouch. Okay, on daytime. On night time, when we lie down, all the entered food particle will come again into the oral cavity, give some bad smell that is called halitosis. If it doesn't enter into the oral cavity, it can enter into the trachea. It could cause aspiration pneumonia. So very important. So halitosis, aspiration pneumonia, barium swallow is the investigation of choice. These are the now treatment is Dollman's excision. So this is an important treatment. Or you could do a procedure called POEMS, peroral endoscopic myoscopic stapling. Okay, POEMS procedure can also be done. Peroral endoscopic myoscopic stapling. Now The most important differential diagnosis VSV is going to start. Differential diagnosis for infra-auricular swelling. They have asked this question once. Okay, they may again ask. A lot of scope in this question. So infra-auricular, if you are having a swelling like this, what are the differential diagnoses? It could be a parotid tumor, it could be a parotid infection, it could be a parotid abscess. It can also be a Ludwig's angina, very, very important. So the commonest parotid tumor is pleomorphic adenoma. What you should look for? Earlobe lift. The consistency is firm to hard. Now, in parotitis, there is absolute tenderness over the parotid region. The tenderness is exerted due to auricular temporal nerve, which is a parasympathetic nerve. It is also having some sensory supply coming through it. So, the nerve supplying the parotid is auricular temporal nerve. Now, this nerve is the causative is cause for the viral etiology causing parotitis. Now, I am having a firm to cystic swelling. What can you think of? Firm to cystic swelling, now you could think of parotid abscess. So all three diseases with respect to parotid. So you should look for earlobe lift, you should look for the tenderness, you should look for the consistency. Okay, sir, I am looking for the consistency. I could not see any earlobe lift. I have swelling all over this particular area. That swelling is a not a uniform swelling. It is a hard swelling or a brawny swelling. It is Ludwig's angina. Ludwig's angina is nothing but submandibular abscess causing infection over that particular area. It is called as Ludwig's angina. Severe pain over that particular area. So what is the reason for Ludwig's angina? There could be rapidly developing cellulitis. The treatment for this is incision and drainage at the earliest. Incision and drainage at the earliest. Okay, we are done with differential diagnosis for infra-auricular swelling, which is the 65th VSV. Okay, so now we are getting into the last 19 VSVs of the day. Retropharyngeal space abscess. Retropharyngeal space abscess, you have to think of the X-ray lateral view. When you look into the X-ray neck lateral view, what you are seeing? You could see a soft tissue density over here. Now, what you are going to do now? This is the vertebra which I am going to count. All right. C1, C2, C3, C4, C5, C6. The C5, C6 vertebra is approximately 20 mm. The prevertebral shadow at this particular area should be approximately less than 18 mm, which means you have to place one vertebra in front of this. This is the normal prevertebral shadow. If this prevertebral shadow is beyond this area, like it should be within the limits of the vertebral body. If you see that it is beyond the limit of the vertebral body, it is prevertebral shadow widening. This is the radiological diagnosis for prevertebral shadow widening. So see here, prevertebral shadow widening, now you should think of retropharyngeal space abscess. In retropharyngeal space abscess, what are the etiology? In adults, if you think of the acute condition, you may think of penetrating neck trauma. In case of children, the most common etiology is dental caries. In chronic condition, be it adults or children, you should always think of TB spine or cold spine. Okay, cold abscess. Now, investigation, X-ray neck lateral view is taken, prevertebral shadow widening is found out. What is the treatment? You treat the condition by incision and drainage under local anesthesia in a sitting position. Why? If you do it in a general anesthesia, the endotracheal tube may injure the abscess. There is no conduit for doing the procedure. So, though painful, you should do this procedure in a sitting position. You make a nick over the posterior pharyngeal wall. You drain out the pus as much as possible. This is the retropharyngeal space abscess. Next one, tonsillitis. So tonsillitis is very important. I have given all the important points of tonsillitis in this single VSV. You please pay attention to this. See here, what are the blood supply of tonsil? Descending palatine artery, ascending palatine artery, tonsillar branch of facial artery. What are other branches? Lingual artery and ascending pharyngeal artery. Totally 5 branches are there. So the descending palatine artery is a branch of maxillary artery. These two are branches of facial artery. Then lingual artery, then finally ascending pharyngeal artery. So 5 arterial supply for the tonsils, out of which the most important supply is facial artery, which will cause profuse bleeding. Profuse bleeding is facial artery. Okay, sir. I am having an acute tonsillitis. There is severe tonsillar congestion. What you have to do? You give antibiotics. Sir, I am having a chronic tonsillitis, recurrent episode of URI, at least more than 6 episodes per year. So what you will have? Chronic tonsillitis. So chronic tonsillitis, you may not do conservatively. You should do surgery as early as possible. So tonsillectomy can be done in rose position. This is the treatment for chronic tonsillitis. Now comes the important MCQ. A person coming to you post-operative tonsillectomy, there is some there is some epistax, there is some blood clots over the tonsillar fossa. So that paratonsillar vein is the commonest vessel for bleeding. If you get a bleeding after tonsillectomy, paratonsillar vein is the important culprit. But the bleeding is very profuse. If you're getting very predominant bleeding coming out of the mouth, that is a facial artery bleed. So minimal bleed, paratonsillar vein, most common. Profuse bleed, facial artery. Okay, sir, I'm getting a post-tonsillectomy bleed. What shall I do? You examine the oral cavity, that is only a small blood clot is there. You give hydrogen peroxide mouthwash, hydrogen peroxide mouthwash, and you wait and watch. But on seeing the tonsillar fossa, if you could see profuse bleeding with frequent swallowing, shift the patient to the theater and ligate the vessel. This they have asked once in the NEET exam. So if the bleeding is profuse, don't wait, you do the repeat surgery. If the bleeding is not there, only blood clots are there, you could wait and watch. Okay. What are the differential diagnoses for membrane over tonsil? So you just please make a note of it. It could be a membranous tonsillitis, diphtheria, infectious mononucleosis, aphthous ulcer, agranulocytosis, leukemia, Vincent angina. These are the differential diagnoses for membrane over tonsils. Okay, this is about bilateral tonsillar involvement, whether it could be an acute tonsillitis or a chronic tonsillitis or membrane over tonsils. What are the aspects about unilateral tonsillar swelling? You please make a note of it. Bilateral tonsil, the problem is always tonsil. Unilateral tonsil, the problem is not tonsil. Some adjacent problem may be the underlying cause. First one, a person is having accumulation of pus between the superior constrictor and capsule of the tonsil. It is called peritonsillar abscess or quinsy. Peritonsillar abscess or quinsy. The patient will be having trismus and fever. So you should start on antibiotics. If it doesn't subside, you do incision drainage at the junction of lower end of uvula. See here, lower end of uvula and the anterior pillar. Okay, anterior tonsillar pillar. So you should mark a line over here and put an incision and drainage over this particular area that will drain out all the pus from the peritonsillar abscess, or otherwise called as quinsy. Okay, it's otherwise called as quinsy. Fine. Okay, sir, I'm having a tonsillar bulge, but I'm not sure whether it is a peritonsillar abscess. Okay, so minimal. The middle bulging will be minimal. Trismus also minimal. The patient able to open the mouth, there is not much of trismus and also minimal bulging of the tonsil. There you could not see any cystic appearance of the tonsil. You think of a abscess called parapharyngeal space abscess. So what is a parapharyngeal space abscess? The parapharyngeal space abscess has two compartments. One is pre-styloid compartment, another one is retrostyloid or post-styloid compartment. So depending upon the area that is involved, the parapharyngeal space abscess can have distinctive clinical features. The first clinical feature is the pre-styloid compartment will be having medial bulging of tonsil, whereas post-styloid compartment will be having important cranial nerve involvement. Okay, so let me show you the important difference between a parapharyngeal space, pre-styloid compartment and post-styloid compartment. See here, this is the lateral view of this particular page. Now I'm having a styloid process. So if the abscess in front of the styloid process over here, see here, here is the tonsils. Okay, so this is pre-styloid parapharyngeal abscess. If it is behind the styloid process, this is post-styloid abscess. Okay, now what is the difference? See here, what are the important neurovascular bundles? You could see a lot of nerves over here, you could see jugular vein, you could see carotid artery. So all important neurovascular bundle are behind the styloid process. So comparing pre-styloid compartment of parapharyngeal space abscess and post or retrostyloid compartment of the parapharyngeal abscess, which is more problematic, post-styloid compartment. And what is the basic difference? This can happen as an external swelling, this can happen as a tonsillar swelling. That is the main difference. Okay, so what is the differential diagnosis for unilateral tonsillar swelling? Pre-styloid compartment of the parapharyngeal space abscess. Okay. What is the differential diagnosis for lateral neck swelling? Retrostyloid compartment of the parapharyngeal space abscess. What is the difference? Here there will be medial bulging of tonsil, intraoral drainage is enough. Here there will be cranial nerve involvement, sympathetic plexus involvement causing Horner syndrome, carotid artery also involvement. You could do a external drainage over the neck. So it happens as a lateral neck swelling externally, that is retrostyloid compartment. Now getting into this question proper, what are the other differential diagnoses for lateral neck swelling? So a swelling over the upper one third of the sternocleidomastoid. You would see a brachial cyst. A swelling over the lateral aspect that is increasing on using a trumpet blowing or nadaswaram blowing. It is called laryngocele. Or a swelling which is abnormally diffuse and it is brilliantly transilluminant. It is a cystic hygroma. So these are the differential diagnosis for lateral neck swelling. We have discussed three distinctive entities: lateral neck swelling, DDs, then infraauricular swelling DDs. Now we are going to discuss midline neck swelling DDs. So brachial cyst, you have to do a surgery, removal of the brachial cyst. Laryngocele, you ask the patient to stop the trumpet blowing occupation, you should shift the job. If it is not recovering now, you should do excision. Parapharyngeal space abscess, you should do external drainage. Cystic hygroma, you should remove it and you should do sclerotherapy for closing the lymphatic pathway. This is actually lymphatic communication failure. So you should close the lymphatic pathway with sclerotherapy. So now we have finished two differential diagnoses of infraauricular swelling, lateral neck swelling, as well as unilateral tonsillar swelling. Now coming to the midline neck swelling. If there is a midline neck swelling, what are the differential diagnoses that you may think of? The first one, obviously, it is thyroid swelling. The second one is thyroglossus cyst swelling. So the thyroid swelling will move only with deglutition, whereas thyroglossus cyst will move with deglutition and protrusion of tongue because it is still in contact with the foramen spicum at the base of the tongue. That is the main difference between a thyroid swelling and a thyroglossus cyst swelling. The thyroid swelling can be benign or tumor. You would have covered more very much in general surgery. Now moving on to thyroglossus cyst. It's an embryological remnant while forming the thyroid gland. So sometimes the cyst may break by itself causing a fistula. So if it breaks by itself causing fistula, there will be midline opening with a discharge like this. So what you should do, a cyst trunk operation. A cyst trunk operation where you would excise the entire hyoid bone along with the cyst. So that is the important treatment aspect for the thyroglossal fistula. Okay, so that's all about the midline neck swelling DDs. Can you see over here? This is a clear-cut picture of thyroglossus cyst. Okay. Moving on to the larynx proper. In larynx, the most important topic is laryngeal palsy. We are having two laryngeal nerves. One is superior laryngeal nerve, the next one is recurrent laryngeal nerve. So the recurrent laryngeal nerve is very important, and if it goes for palsy, it should be immediately attended. Now, the recurrent laryngeal nerve, what it will do? It supplies all muscles of larynx, which is a motor supply. Sensory supply is below the vocal cord. Understood. Now, if both recurrent laryngeal nerve goes for palsy, it causes bilateral recurrent laryngeal nerve palsy. What it will cause? It makes the vocal cord to be in paramedian position. Can you see over here? This is the paramedian position of the vocal cord. If the vocal cord lies in the paramedian position of the on both sides, it may result in stridor. So, among the combination of the laryngeal palsy, superior laryngeal palsy, both nerve palsy, recurrent laryngeal palsy, bilateral recurrent laryngeal palsy is the only condition with stridor. So, if they give stridor in the question, you should close your eyes and you immediately think of bilateral recurrent laryngeal palsy or bilateral abductor palsy. Both are same. Okay, fine. Okay, the vocal cords are in paramedian position. What can you do for this patient? You could make the vocal cord to move away from each other by doing type 2 or lateralization thyroplasty, or you could do a lateralization suturing, or you could do a reinnervation procedures, or you could do a procedure called as Dennis Keshima procedure. So you may not heard of this procedure, but of late this is the gold standard procedure. You should remove the posterior one third of the cord together with vocal process of arytenoid. So this is the gold standard treatment for. If they have given Dennis Keshima procedure in the options, you should definitely pick that. If it is not given, you may pick other options. Okay. So Dennis Keshima cordectomy or arytenoidectomy is the most gold standard procedure for bilateral recurrent laryngeal palsy. Okay, sir. I have known about recurrent laryngeal nerve. What about superior laryngeal nerve? Does it not have any function? Yes, it is having function. Superior laryngeal